It's my pleasure to introduce Dr. Telisa Spikes, who is the assistant professor in the Nell Hodgson Woodruff School of Nursing. She obtained her bachelor's in nursing from Georgia Baptist College of Nursing, and then she got her master's in nursing in advanced care management and health policy from Kennesaw State University. She graduated with her doctorate in 2019 from Emory. Her research focuses on the relationships between adverse social stressors, inflammation, and cardiovascular disease risk, with a specific interest in subclinical cardiovascular disease and hypertension in young adult African American women. Dr. Spikes has been a long-time member of our Emory Women's Heart Center team involved in community screenings, the 10,000 Women's Hypertension Project, publications with team members, and this annual CME. So with that, I'd like to cue up Dr. Spikes' talk. Her talk is going to be on social determinants of cardiovascular disease in women and the impact of maternal mortality.
Good afternoon. My name is Dr. Telisa Spikes, and I am an assistant professor at the Nell Hodgson Woodruff School of Nursing at Emory University. Today, I am honored to be able to share with you all information on an important topic entitled Social Determinants of Cardiovascular Disease in African American Women and their impact on maternal mortality. Before I begin my talk, though, I just want to add and state that social determinants can be a touchy subject, and my goal is that by the end of this presentation, that the audience feel comfortable having these discussions amongst colleagues, but also being more comfortable addressing some of these concerns in your clinical practice. And then for my fellow researchers, feeling comfortable, but also understanding the importance of incorporating social determinants into your research. I have no relevant financial disclosures or conflicts of interest to share. Briefly, my outline will go as follows. I will open up defining what are social determinants and their implications on overall health, discuss prominent social determinants of cardiovascular disease in African American women, as well as the implications of social determinants for maternal mortality, and end by discussing targets of multi-level interventions to reduce cardiovascular disease burden in African American women. Healthy people define social determinants of health as the conditions in which people are born, live, grow, age, play, worship. And these things affect a wide range of health, including health risk, overall functioning, and quality of life outcomes. As you can see here, social determinants of health span to include economic stability, neighborhood and physical environment, education, food, community, and social context, as well as the healthcare system. Lincoln Phelan, two prominent epidemiologists who wrote The Fundamental Cause of Illness, has suggested that social conditions are the fundamental cause of disease, since health outcomes do not occur independent of the social conditions in which they exist. Social determinants are considered to be highly interrelated and difficult to categorize, as they often occupy more than one dimension. Briefly, some of the key social determinants of health that have been linked to cardiovascular disease disparities and attributed to cardiovascular disease disparities include race. We know that racial ethnic minorities are disproportionately burdened by poor health outcomes, specifically the health of African Americans, a group that is designated to have the worst and the most for many of our prominent comorbid conditions. Additionally, there is a 14-year there's a 14-year difference in life expectancy between the Asian Americans and whites, which is roughly about 85 years, contrast to 71 years for African Americans or Blacks. And I will use the term African Americans and Blacks interchangeably, but please recognize I am addressing the same group. Adverse socioeconomic conditions have also been associated with poor health. I will speak later about income and wage inequities between African American women and white women, and how this also may play a role in the development of cardiovascular disease. There are also disparities that are prevalent in the access to high quality cardiovascular health care. Additionally, when care is assessed, it is met with bias and stigmatization from the providers, which affects quality of care and outcomes. There are also residential factors that have received increasing attention for its role in the disparate cardiovascular outcomes between African Americans and whites. And I'll also discuss more of that later in the presentation. Psychosocial stressors are considered another potent cardiovascular risk factor. But we do know that stress is not limited to one race or group of people. However, some forms of chronic stressors are more prevalent among African Americans, including financial strain and race-related stressors, such as over-policing and police brutality among the Black community. And then lastly, psychological well-being, the overall social context or lived experience of African Americans that is associated with hardship and struggle has also been associated with worse psychological well-being, including poor self-ratings of health, depression, anxiety, and anger and hostility. The connection between poor psychological well-being and cardiovascular morbidity and mortality is also believed to be the result of chronic and sustained activation of the body's stress response systems, causing perturbations in immune functioning. So before I move forward, I wanted to just briefly highlight some key terms that I'll use throughout this presentation, and I just want to make sure the audience is well versed as to their meanings. So according to the discrimination research literature, interpersonal racism is the most prevalent form of racism, and that's the form of racism that is more likely to be experienced in the day-to-day lives of people of color and minorities. And it's defined as the personal prejudice and intentional bias in our individual interactions across different races. Institutional racism, however, is defined as the unfair policies and discriminatory practices of particular institutions that routinely are suggested to routinely produce racially inequitable outcomes for people of color, but also while advantaging white people. And then structural or systemic racism, defined as the cumulative and compounding effect of an array of societal factors, such as history, culture, ideology, and interactions of institutions and policies that systematically privilege white people while disadvantaging people of color. Social determinants of cardiovascular disease in African American women. So why is it important? Here you see images of two Black women that I will discuss a little later in the presentation. And I feel that stories have more of an impact than just research data and clinical findings, because it makes the stories real and it brings all of these bodies of evidence together, and it puts a face with what we're discussing today. So there is no single causative factor responsible for the health disparities and inequities of cardiovascular disease among African American women. However, many of these factors are compounded by and often rooted in a system of structural racism. I also must be very clear and state that many of these findings do not apply necessarily to all Black women. However, most Black women are indirectly impacted or affected by these issues, if not directly by them, through others that are connected to them. So in the first study I want to share by Smilowitz and colleagues, they examined adverse trends in ischemic heart disease mortality. So beginning at figure A, the Black line denotes Black women, red, white women, blue, Hispanic, and purple, Asian American women. And they found that women 35 to 54 years, Black women had the highest rates of ischemic heart disease mortality. And if you look at this smaller box, not only did they have the highest rates of ischemic heart disease mortality, they had a more stagnant decline in ischemic heart disease mortality compared to the other racial groups. When we look at figure B, men of the same age group in the same color line depicts the same racial groups. There was no significant difference for ischemic heart disease rates between Black and white men or Hispanic and Asian men. So in a more recent study that was done by Vaughn and colleagues, where they examined national and county level annual counts for heart disease using the National Vital Statistics System data, they found, beginning with this first figure, that the rates for heart disease were slightly higher for African American or Black women, denoted here in the solid black line, compared to white men in the dashed blue line. When you go over to the next figure, they repeated this analysis stratified by states, and what they saw, including the DC territory, they found that it was the same similar pattern of association, but the pattern was more pronounced in that Black women had a higher death rate from heart disease compared to white men of the same age group. So considering that heart disease mortality is considered to be normally lower, particularly among this age group, which has been suggested to be due to the protective biological factor of estrogen, these investigators suggested that social and environmental factors may actually play a more important role in overriding the biological protectiveness of heart disease mortality in this younger age group of women. So in order to understand how social determinants impact cardiovascular disease risk in African American women, it is important to consider the impact of policies that are embedded in a longstanding institution of structural racism and the impact these policies have on socioeconomic status, neighborhood, the social environment, and psychological well-being. So I will not focus on policies because that's not the scope of this presentation, nor is it the area of my research, but I will shed some insight into how some of these policies may have influenced each of these dimensions briefly. So earlier this year, Essence magazine released an article, and they were interviewing African American women to understand how has COVID affected them from an economic standpoint. And one participant stated that I must have forgotten to carry the one because things did not add up. I was brilliant and broke, educated and unemployed. I had 2 degrees and an EBT card. And the point of this quote is that this is more of a norm, even in net of a global health policy, global health crisis such as COVID. So when we talk about socioeconomic status in African American women, some key findings that I want to share with the audience is that in 2017, the median earnings for African American women were roughly $36,000, contrast to the nearly $44,000 annually earned by white women, a difference of roughly 21%. Additionally, African American women, with data from the Brookings Institute, is shown to earn 63 cents for every dollar earned by a white male, contrast to white women who earn 79 cents to that of a white male. Additionally, African American women have poverty rates that are twice as high, which can partly be explained by the wage inequities between African American women and white women. Also, African American women are more likely to be the sole household income earners, and which also place another financial strain or challenge because many of these women have children or codependents or maybe even extended family members residing in the house with them. So that means assuming a household and taking care of a household with fewer resources. And then lastly, African American women across all racial groups are the most burdened by student loan debt. African American women have 22% more in student loan debt compared to white women. So, and these were the hard figures that came from a recent study. So for my postdoc, one of my first projects that I looked at was understanding how SCS impact cardiovascular risk but specifically incorporating a measure of wealth. And wealth is not widely used in health research, but I think it's important to include because of the disparities in wealth attainment between Blacks and whites. But in this study of a cohort study of African American women, 30 to 45 years, we found that women who in net worth was assessed with a single item. So women were asked, if you were to liquidate all of your assets, including your home, would you have something left over defined as positive net worth? Would you break even, net neutral net worth, or would you still be in debt or negative net worth? And what we found was that a similar pattern of association for both 48-hour daytime and 48-hour nighttime systolic blood pressure, that there was a 6 millimeter of mercury higher daytime and nighttime systolic blood pressure among women who reported a negative net worth compared to those who reported a positive net worth. So transitioning now to neighborhood and CVD risk. So we know that established mediators that have linked neighborhood residential segregation to cardiovascular disease risk include poor access to health promoting resources, less exposure to safe residential areas, and reduced access to high quality care. Voluminous data has also shown that African American women have a higher cluster of traditional cardiovascular risk factors. But why? Beyond individual, behavioral, and lifestyle factors, socioeconomic, policy, and environmental influences are also suggested to contribute to a greater burden of cardiovascular disease that's not seen in whites. So using findings from a study from Kershaw and colleagues, where they examined neighborhood level race and ethnic residential segregation in incident cardiovascular disease using MESA data, which is a popular epidemiological data set, they found that for each 1 standard deviation increase in segregation scores among Blacks, it was associated with a 12% higher hazard of incident cardiovascular disease over a 10-year follow-up. And this was even after adjusting for potent cardiovascular risk factors such as blood pressure, BMI, smoking, alcohol consumption, and physical activity. As you can see, this association was not observed among whites. And then there was also a similar pattern of association for incident coronary heart disease as well. So as I was preparing my talk, I came across this article and I thought it was so timely. And the one quote that stood out to me, so the title of the article was Affluent and Black and Still Trapped by Segregation. But one quote that was used in the article was that affluent Black families freed from the restrictions of low income often end up living in poor and segregated communities, further met with rising crime. Researchers in this area have suggested that this trade-off may come at a high health cost in that African Americans tend to lack the space or freedom to be physically active due to the crime and safety concerns. And this also may function as another mechanism by which neighborhood context increases the risk for the development of cardiovascular disease. So now pivoting to the social conditions and CVD risk, I had the opportunity to attend a conference this summer and Dr. Zenobia Hikes was discussed. And I thought it was so appropriate and it resonated with me because this is largely the focus of my research, but more so in younger African-American women. But the story behind Dr. Hikes was that she was the former vice president of student affairs at Virginia Tech. And she was there during the Virginia Tech massacre that occurred in 2007. The long and short of it was that Dr. Hikes succumbed to complications post-open heart surgery. So she had to have open heart surgery because of heart disease. But a quote that her daughter stated was that, her mother had overcome, poverty, breast cancer, sexual assault, and domestic violence to rise to work in academic administration at some prestigious universities, only to die roughly, I think she was like 55 years of age. So hearing her story made the term, and I'm sure some of you have heard of it, by Dr. Arlene Geronimus, weathering, which is, as Dr. Geronimus states, is beyond anything that an individual has control over. And it is not something as simple as, stopping smoking or poor diet or get more exercise. But this term of weathering posits that the stress that's inherent in living in a race conscious society that stigmatizes and disadvantages Blacks may cause disproportionate physiological deterioration, such that a Black individual may show the morbidity and mortality typical of a white individual who is significantly older. So, and it's not now, as we see, it's not just socioeconomic, but it's just a cumulative compounding effect of these stressors that have incurred. And so, and to see that play out with Dr. Heights, it makes the hypothesis real, which is why I wanted to share that story with the audience today. But using the figures from the study, the pivotal study from Dr. Geronimus, where she examined NHANES data to calculate allostatic load scores, which would be a quantitative measure for weathering, where she looked at these different, several physiologic constructs to measure, okay, what type of allostatic load is occurring between Blacks and whites, and how does this differ by sex? And what she found, beginning in figure A, was that Blacks at all ages had higher allostatic load scores compared to whites. Additionally, they also found that Black adults, particularly at 35 to 64 years, had a greater probability of having higher allostatic load scores. Black women, had a greater probability of having higher allostatic load scores compared to Black men. By age 45, 50% of Black women had a high score, but by age 64, more than 80% did. Contrast that to white adults. These are white women, white men, and these are Black women, Black men, white women, white men. They found that white adults reached the 50% level as they approach age 60, but it never peaked much beyond that. So now transitioning to the psychological well-being and cardiovascular risk. So currently what we know is that there is a dearth of longitudinal research on the nuances of the mental health and cardiovascular health of Black women. Most notably, Dr. Cheryl Woods Giscombe, who's an African-American nurse scientist, she developed the Superwoman schema or Superwoman phenomena framework to better understand how African-American women experience and process stress, and how this combination may influence health outcomes, not just cardiovascular disease, but a broad array of health outcomes. Additionally, we know that economic and social environmental factors appear to contribute to chronic negative psychological states, which may result in dysregulation of the autonomic and sympathetic nervous system, to which the body's physiologic system is constantly operating at a heightened physiological state and unable to achieve balance, or their pre-stress states. And we know that the presence of chronic stressors tend to reduce coping resources and increase vulnerability to poor mental health outcomes. So a snippet from my dissertation study, where I examined hypertension illness beliefs, resilient coping, and hypertension medication adherence in African-American women 18 to 45 years of age, I was surprised to see such a high proportion of young women reporting depressive symptoms. But specifically, when you look over here to the first graph, Women who had high depressive symptoms denoted in the goal held a more threatening or pessimistic view of hypertension as a diagnosis, meaning that they saw it more as a fatalistic view that it was not able to be controlled. And these women also had higher systolic blood pressures. But when we look over here to the second graph, examining the association among education, resilient coping, and depressive symptoms, I also saw that there was an inverse association. So women who were more resilient and had this view that they could overcome this hypertension diagnosis tended to not have depression and had higher resilient coping, as opposed to women who were depressed who had lower resilient coping scores. So what are the implications of these social determinants on maternal mortality? So this is Dr. Shalon Irving, and I included her picture along with Dr. Heights as I was getting ready to start going into these conversations. So a little bit of background about Dr. Irving is that she was a CDC epidemiologist at the CDC. And unfortunately, she succumbed at 36 years of age, 3 weeks postpartum, due to complications from high blood pressure. And this is Dr. Irving with her newborn baby and her father, and Dr. Irving's mom and her daughter now. And her mother has started a nonprofit to help address and combat maternal mortality faced among African American women. And one quote that her mother stated was that Black women are not being seen or heard when it comes to their health, especially during and after pregnancy. And that was a big issue for Dr. Irving. Postpartum, she developed complications. She kept going back to the doctor and they kept attributing her symptoms to just, oh, it's fatigue, it's normal, you just had a baby. But she really was having a cardiac event going on, but the signs kept being ignored. So African American women are 3 to 4 times more likely to die of pregnancy complications than non-Hispanic white women, seemingly irrespective of their academic or economic attainment, which were previously thought to be protective from adverse maternal health outcomes. Additionally, African American women 30 to 39 years of age are also twice as likely to die from pregnancy-related complications as women in their 20s. So the implications for maternal mortality include that among Black women, there is an inequitable distribution of preconception cardiovascular risk factors such as obesity, hypertension, and diabetes. Pregnant women with both chronic hypertension and pregestational diabetes appear to have higher risk of adverse obstetrical outcomes, including preterm birth, and preterm birth before 32 weeks, and 3 to 4 times more likely to succumb to maternal mortality. In 2019, there were 20.1 deaths versus in 2018, 17.4 deaths per 100,000 live births. And we see that this number is continuing to trend up, and we need to see it trend the opposite direction. Regardless, it is critical for clinicians to be vigilant not only during the prenatal and antepartum period, but postpartum period as well. And then stigmatization and bias, exclusively addressing individual behaviors as the basis for health outcomes without considering a structural perspective of how social determinants influences and shape health disparities and health inequities in African American women further perpetuates these inequities and additionally contributes to the racial disparities that we are seeing. So where do we go from here? Lifestyle changes, even when they are successful, do not address the stressors and the challenges of living in a racially charged society. And therefore, multi-level strategies are needed. And we as clinicians and health researchers are poised to make substantial contributions that are greatly needed. The Association of Black Cardiologists developed a new care delivery model that spans from preconception to the postpartum phase of care. And not only did they develop this model to address the common problems that are associated with each phase of care, but they also offered proposed solutions And I'm going to briefly highlight on some of those that have been included from their review, but also through the literature on maternal mortality. So beginning with one, let's acknowledge the symptoms and concerns of Black mothers. Primary reason for the suboptimal care of Black women during the prenatal and postnatal period is attributed to the dismissal of their symptoms by clinicians. We need greater research, a greater investment in research that's aimed at the social factors that contribute to the racial, sex, cardiovascular disease disparities in young Black women. These issues can be difficult to address, but it does not have to be. And once we learn what's within our scope of what we can address, we are better poised to help make those changes. Active engagement with community stakeholders and strategic partnerships with community residents by identifying health priorities. Communities represent the settings in which health is supported and protected or risked and damaged. And therefore, it is essential and should ideally include community thought leaders, diverse government and non-governmental organizations, as well as small businesses, fraternities and sororities, in addition to academic health centers and local public health departments. And then care models targeting health barriers during the prenatal, antepartum, and postpartum phases of care. For instance, the Association of Black Cardiologists, they're currently working with insurance companies in providing or extending coverage through the postpartum period, which currently stands at a 90-day window or one visit that they cover 6 weeks postpartum. Evidence and data has shown that 33% of maternal deaths occur between 42 and 365 days postpartum. So extending coverage 1 year out can help curb the risk of adverse health outcomes in this high risk population of women. Embracing dissemination and implementation research in hypertension control. An example of this is collaboration between the media and healthcare organizations, which I think American Heart Association does a wonderful job of this, in using influential Black women to share their stories to increase awareness. An example of this is Beyonce, when she recently had, when I say recently, in the last 3-4 years, she had her twins, and she said that she developed preeclampsia and had to have an early delivery because of that, and her blood pressure and swelling. Interventions targeting coping strategies that may mitigate cardiovascular disease risk in Black women are needed. Although many of the aforementioned chronic stressors discussed here that are experienced by Black women are difficult to modify at the individual level, such as discrimination, racism, and low socioeconomic status, coping strategies that target how these women address these challenges may impact stress-related behavioral and physiological pathways that influence cardiovascular disease risk and outcomes. Increasing a diverse clinical workforce, as studies have shown racial concordance between patients and the provider results in improved quality of care and health outcomes overall. Investment in Black women scientists, as well as mentorship, have a key role to play in developing cultural sensitive approaches to better capture the burden of chronic stress that's experienced by young Black women and effective approaches to reduce it. So in closing, I would like to leave the audience with this, that interventions that solely focuses on personal lifestyle while ignoring structural and cultural factors are less likely to have an impact upon the health disparities sustained by African-American women. And thus challenging circumstances requires out-of-the-box thinking. So with that, I would say thank you for your time and your attention. Now I will go live for any, join you live for any questions that you may have that I may be able to answer. And again, thank you for your time.
Good afternoon, Dr. Spikes.
Hi, Dr. Izzy Denzel, how are you?
Great. Thank you very much for your talk. It's something I would have to say that we as clinicians may be aware of, but don't think about how it impacts the health of our patients, specifically the social determinants of health. And I guess I'd like to start with that is when looking at our patients, from what you're suggesting, we should look at them as a whole individual, certainly, not just the individual who comes in with hypertension, but possibly taking into account the environment that they live in, some of the financial concerns that they may have, and maybe why they're not able to adhere to the medications that we prescribe. How do you recommend clinicians actually take this into account and implement any solutions with our patients that we are seeing on a day-to-day basis?
Well, I think that's a great question. And I think it just starts one, I'm sorry, it starts one with just the rapport. Talking with your patients, communication is key in just understanding and asking, how are you doing? Do you have any concerns or barriers that you feel may be prohibiting you from achieving your best optimal health? Something just that basic. And believe it or not, when you express or even ask those types of questions, and it shows a concern or a level of empathy where the patient would be more inclined to open up and share more. I had the privilege during my dissertation study to recruit several women from Grady, and they are very aware that we're not in a position to be able to change their social lives, but sometimes it's just good to be able to just communicate what challenges they may be having. And so in some things we may have within our scope to change, just, for instance, when they enrolled in my study, I was able to give them, incentivize them for participating. And I could not believe that $25 was viewed as if I gave them $1,000, because they said, a few of them, that they were not able to get their blood pressure medication because they didn't have the money, or they were not able to get to Grady, even though they could get their medicines for free, but they didn't have the money to get the transportation. So it's those little things that I think we as clinicians can do, just that communication, just to see, how are you doing? What can we do? Are there any barriers that you're facing that's prohibiting you from achieving your optimal health?
Yeah, I think what I also take away from what you're seeing is just making sure the patients feel seen and heard. They're not
Exactly.
there just for us to fix them with the next medication, but in this opportunity that I have to talk to you, do you see and hear me as a whole individual?
Right.
Um, and I do think that, I know that there are some challenges, or I should say, constraints when it comes to resources, but I do try as much as possible to lean on even other departments. So if I saw a patient of mine who I share with an internist, and her biggest issue is literally while we're doing the visit, yes, she has orthostatic hypotension, yes, she has diabetes, but she can't even hear me because she's got severe hearing impairments and she can't see. So I'm typing to her on using 72 font on the screen and screaming because she can't even hear, but to be able to allow her to see, we have to type that loud. So the visit, which should be 15, takes 45 minutes, but
Mhm.
it was appropriate because for me, it wasn't just how are you doing today with your blood pressure, but how can I help you so that you're on your day-to-day living outside of this office, that you're able to get your medications, that you're able to communicate with other individuals. Because if we can't do that, that's going to be a challenge with compliance with medications and
Right.
being able even to get to our visits. If she can't even reach out to somebody to communicate, listen, I've got an appointment on Monday, who's going to be able to take me? So her primary care doctor has a social worker who she enlisted to see if they can help her get a hearing aid at Grady because she got a grant to get that done. And what can we do about her vision? So I think you make a good point. Is just understanding some of the other factors that play a role and impact an individual's health, and how we can empower or try to find out any solutions that are helpful in order to improve their overall health.
Right. Right. And it's little. I mean, that doesn't take much, you know.
And reminding ourselves that we don't have all the answers, and again, just employing any outside resources that are available.
Right.
One thing that we talked about and we've heard from other speakers are the increased cardiovascular risk as it relates to pregnancy related complications. When we talk about the increased maternal mortality, do you think that occurs due to decreased awareness among providers or amongst even patients about the risks of increased mortality if they have these pregnancy related complications?
I think it's, well, according to the literature, it's both. I'll give you two examples. So recently I was on a work group where one of the midwives, she's actually doing a research study, and she was going over just some basic things you need to know to this new mother postpartum, because she had a history of hypertension. So signs to look out for, swelling, shortness of breath. And she had no idea, she had no idea to look out or report those symptoms because she thought that was just a normal part of being pregnant. Contrast to, as I was sharing with Dr. Irving's story, she was educated, was very well aware of her risks, and she kept going back to her provider saying something is just not right. And her providers kept passing her off that, this is normal, it's postpartum, you're supposed to feel this way, until she didn't wake up. So, it's a two-way street. And
I
I
know
think
here at,
education for both
sorry,
is imperative.
I was just going to add, and I correct me if I'm wrong, if you're not part of this work group, but the Emory Women's Heart Center is working closely with our OB/GYN department over at Grady and over here at Emory University Hospital to form a work group that looks at maternal mortality and how can we as clinicians change the landscape, what can we do as far as even consider policies and practice changes to improve that. Do you know anything about the maternity mortality rates here in Georgia?
The most recent that I saw was pretty similar to what I reported nationally. I do know that Georgia, sadly, is ranked number 2 in the has the second highest maternal mortality rate. And I think it was 2019, it was 27, or actually this year, 27.7 deaths per 100,000 live births. So pretty close to the national average, which is too high.
We know about the impact of stress and depression on cardiovascular disease risk. Do you have any suggestions for coping strategies in Black women? You touched on the importance of that, but do you have any suggestions for clinicians?
So one thing, an emerging area that's research that's growing, and Dr. Berkowitz had spoke about this earlier, about this phenomena of resilience, but resilience is a great attribute. It has historically been known to be very protective against many of the adversities of life. But what happens when these women are subjected to chronic forms of stress? Research shows that when you're repetitively faced with these chronic stressors, it has the potential to mitigate or diminish these protective health resources. So a big thing is just, one, screen these women to see, are they depressed? And I really think it's important that we begin to normalize and foster speaking to counselors. This is something that has not been normally done in the African-American community. But one thing I must say with the pandemic that has brought out is just really this need for people to talk to people, because I mean, this has been a traumatic experience for all of us. And so I think since then, or since this pandemic, we have began to sort of normalize, it's okay to talk to people. It's not viewed as a sign of embarrassment. So I think that's one thing that clinicians can do, because you can't do it all. And we do not expect you to do it all, but those things that can be referred off, such as speaking with people, that's a start. And it has shown to be very helpful. We live in a world of social media. So I have seen even many of these young African-American women state, I never would have seen a psychologist, or I never would have talked to someone. That was just not the way I was raised. But having done so, this was the best thing that I could have done. And I see it a lot. So I would strongly suggest and encourage providers to refer their patients if they feel the need to speak to someone, do so, and make it feel safe for them and not as a sign of embarrassment or shame.
Absolutely. I have found that some patients come and usually the first 10, 15 minutes in the office is really just sort of talking about those psychological stressors and even other social determinants of health that you touched on, whether it's they've got children in school and trying to be available for them and financially support the rest of the family while they've maybe down to one household member who is bringing in an income and a loss of job, all these things that the pandemic has brought out and the challenges that has imposed upon them, and then their health becomes secondary.
Mhm.
So again, seeing them as a whole individual, acknowledging those um, barriers that they may be facing in order that prevent them from engaging in their overall health, but reminding them there is help out there, and then I'm here to support you.
Mm-hmm. And the good thing I will say too with the pandemic is that even more psychologists have spoken up to make themselves and their services available, because that's part of the problem. Some women just do not know where to go or how to start to look for providers. So
Absolutely. Well, thank you very much, Dr. Spikes, for your talk. We appreciate you presenting to our group this year.
thank you.